So, to pick up on Denny's introduction, I'm here to come out of the closet, bring my research out of the closet, I guess, more appropriately. And I want to pick up on something that actually Tim and David started this morning when Tim asked, so can we really give up on these other endpoints for ones that are easier to measure? And so that's the subject of this talk here. I'll do the best not to, I don't think I have one Greek symbol in this, much to Tim's disappointment. But I do want to acknowledge some former graduate students. I hope that someday Tom will be on this list. I have Judd Blatchford, Mark Tripudi. Let's see, does that help? Maybe. Mark Tripudi, Xiang Yin, and Neil Goldenberg is a clinical collaborator in the example that I'll be presenting. And so what I want to talk about is, we always are considering multiple things, multiple endpoints, really in any study, and I'm going to talk about clinical trials here, but these extend to anything you're doing where you want to make decisions along the way. And really, in the course of my lifetime, I'm always making decisions along the way, aren't I? And so are we from public health. You go back 20 years, I'm sure things look different. At any rate, so we often ask many questions. Will lifestyle intervention, for example, reduce the risk of diabetes, or is it sufficient to show reduction in blood glucose? Sildenafil, pulmonary arterial hypertension, is another area I work in. Do we want to improve physical function, 6-minute walk distance in this case, or is it good to see effects on disease process like pulmonary artery pressure? So our current methods, hence what I want to extend, the problem here is that typically when we're doing DSMB work and we're looking to monitor trials, we're monitoring a single primary endpoint. And often, though, if you sat in the room in a DSMB, many things are considered when you want to make a decision on whether or not you should continue or stop a study. When you're considering all this mix of things, you're in fact affecting the statistical operating characteristics, and it matters. Not just from a statistical point of view, but from the science, which is what I hope to look at, possibly extending these things. I'm going to look at 2 dimensions because that's hard enough. But I want to look at the effect on both scientific integrity and trial efficiency. So I'll be using this example through most of the talk. I meant to start something that would tell me how long I've got. There we go. So VTE, or DVTs, are clots in your blood veins, which aren't a good thing, can lead to stroke, pulmonary embolism, and death. Children also have these things, and in fact, Neil Goldenberg says that 1 in 200 hospitalized children are diagnosed with VTE. Standard treatment in adults is to give 3 to 6 months of anticoagulation, either with warfarin or heparin. And the goal is to reduce the risk of recurrent VTE. You don't want another one. But the risk is that you anticoagulate and you get major bleeds, which can themselves be life-threatening. But as in many cases, evidence in children, as people like to say, children are not just small adults. The standard approach is to roll out the things that have been accepted in adults to the pediatric population. But children, in fact, have a lower risk of recurrent VTE, and so the question is, are we overtreating? So we have a clinical trial, the KIDS-DOT, duration of therapy for thrombosis in children. The question is, can we look at short duration treatment, and does it have equivalent efficacy, and then does shorter treatment then reduce the bleeding risk? So we're randomizing 570 children, 285 per arm, to receive either 6 months or 6 weeks of anticoagulation therapy. The endpoints are the classic dyad of do you get more clots or do we cause bleeding? This is a non-inferiority trial, so we want to show that these things are basically equivalent. That's the point. Non-inferiority is a whole nother lecture, and as much as I like to hear myself talk, what we're going to choose is a critical value here. So the point at which, in this trial, we're going to require that the point estimate not be in the negative direction. That's just a decision we've made. And then to choose the information, if we see that, we want the the confidence interval to rule out a 5% increase. And those combination will determine the sample size. That's where this 285 came from. Okay, so what would we do with a usual trial monitoring plan? So first, before I get to what I'm going to want to focus on, of course, is, well, I'm going to want to look at both of these. But what if we just did the usual thing? And this would be a usual trial monitoring plan. 570 total. If we get to the end, we're going to, if it's above 0, if the point estimate is above 0, we're going to decide inferiority. If it's below 0, we're going to decide non-inferiority. And the negative numbers are decreased risk. Along the way, if we see evidence that that we have too much evidence in the wrong direction, we're going to decide it's inferior. And we'll do interim analyses after 200 and 400 subjects have reached their final outcome. So I want to demonstrate, as introduction to the bivariate question, what happens to the sampling density. We're used to dealing with asymptotics, at least I am, and you've got that classic Gaussian curve, and you change the mean, you just sort of pick it up and put it down someplace else, and the variance is the standard error, and that you can control with your sample size. You're used to just kind of flipping things around. Well, what does this sequential monitoring do to such a density? And so here's why I'm using my Mac. I want to first, so I'm going to R, and there we go. So I have this multimedia extravaganza here. So here's the same design I was just showing you. And this is the beauty of biostatistics in the closet, is I don't actually have to do this trial. I can simulate it. So I'm going to suppose that the true mean is in fact 2% in the wrong direction. And I'm going to do my trial. And so what happens? Well, the trial unfolds. This particular rendition of the trial went until it missed stopping at the first interim analysis, but it stopped at the second with a decision for inferiority, not non-inferior. Well, what if that random pathway were not the one my trial followed, but what if it were this one? Well, happened to stop at the same one. But that trial there, went to the end and reached the decision of inferiority. Ooh, that one went to the end and decided it was not inferior, even though the true effect is 2% in the wrong direction. And so rather than do each of these 4 or 5 trials, I'm going to do 100 because I can. This is a demonstration of what happens to the sampling density. If I didn't have these, floodgates here along the way, all of these sample paths would have ended up over here, clustered around the true mean of 0.02. And so what's happening is this sampling density is being filtered. And so what's the result? Well, our sampling density ends up looking really weird. It's no longer that classic Gaussian shape. It's now got jump discontinuities, and what I didn't show you is if I switched the mean, in fact, maybe I should try to go back and do that again, because I can. So what happens if this were at 5%, say? Let's see what happens here. I've got plenty of time, don't I, Sam? Now I've got to go find that window. It's called quartz. There you go. So I changed it to now, if I have 5% in the wrong direction, most things are stopping at the early interim analysis. If I, in fact, have no difference, so the true mean is 0, then what's going to happen? Well, you can probably guess. Most of them are going to go to the end. A few of these sample paths are going to get sucked off because of false inferiority conclusions. So, in fact, about 50% of them end up in the non-inferiority range. That's called the power. Okay, so this group sequential sampling density has jump discontinuities, and it is not shift invariant. I can't just change that mean there to 0.5 or 0.05 and have this just move over. The relative heights of these peaks changes as I go to 0. This one got much bigger, and these two got very small. So we need special methods to do this. But this is not just a function of the particular, it's a function of the particular stopping rules we use. So most of you on DSMBs have heard of O'Brien-Fleming stopping rules. And so what happens with this? What happens when I have different kinds of stopping rules? And to illustrate this, I really need to invoke, I'm sure you've wondered what this is about. I really need to invoke the superhero. So here we go. Got it. This is the only statistical talk you've ever seen with Batman in it. So, mission accomplished. Okay, but where'd the rest of my talk go? So, why do you think I did that? Well, guess what this sequential sampling density looks like. Ta-da! So yes, as my respected colleague once said, you have the coolest sampling densities. So we have to deal with this. But now what happens as we roll this out into a bivariate space? So now we've got two endpoints. I have VTE here going in the east-west direction and bleed, benefit harm, going in the north-south direction. So if we're monitoring a single endpoint, then we're just splitting this bivariate space according to that single endpoint. So here's statistically significant VTE benefit. Here's statistically I've met my criteria for non-inferiority, and here's harm. But really, not all of this, the gradation across bleed is not constant, right? Up here, I'm reducing VTE risk, but causing bleeding. Here, I'm causing clots, but reducing bleeding risk. So what we really need is something that's a little more scientifically and clinically relevant. And so these equivocal regions, we have to figure out where does the trade-off lie in this space. I mean, here things are clearly bad. They're bad on both endpoints. Here things are clearly good. They're good on both endpoints. Here it's non-inferior. But somewhere there's a line in between them. So in the kids.dot trial, we had to go to the clinical colleagues and say, what's best here? What is a reasonable stopping rule? And after a lot of discussion, we decided on this. So we've now split our bivariate space into areas where the bleeding and VTE protection trade-off is in the wrong direction. We're going to decide against short duration here and decide for short duration if we're in the benefit region, or where they're both benefit. But there's a trade-off. The amount of trade-off we're going to accept in terms of increased bleeding risk depends on how much VTE protection we might have, or more likely, the amount of VTE increase we might accept with short duration is going to depend on how much bleeding risk reduction we can have. And this generalizes. You should be thinking, well, one of these is a surrogate, one of them is the primary endpoint, and that's where this talk is generalizing as we get to there. So this is how we came up with those. We considered inference, this is just marginal confidence intervals, at 3 reference design points. Just like you pick design points in anything, we thought, well, we need reasonable conclusions at these design points. And we chose a curve according, I've got a whole family of curves. That's the job of the statistician in the closet. But a whole family of curves that allow you to specify this in a way that is actually clinically interpretable and has a hope of being implemented. And so now, once we decide on the stopping rule, we can look at monitoring such trials. And this is really where it comes into play, is if we're just going to do the whole trial regardless, then in our choosing our sample size, we've decided there's an amount of information we need across all endpoints, and we're going to make those trade-offs after we've got that information. But if we're going to do interim analyses and consider multiple endpoints, we, of course, are giving up on that information. So we're going to stop early, say here at the first interim analysis, because things aren't looking good, but we're going to give up on any further information on the bleeding VTE trade-off, that there's enough information on the direction these are headed that we're going to give up on that. And so what on earth does this do to our sequential sampling density? Well, I had another simulation, but I won't I instead have work from Xiangyan, who actually was looking at a different problem. But suppose this is a bivariate decision rule, just it's rectangular. You have similar things that you can do with this, but I don't have them worked up in this way. And so what happens to the sampling density now that I stick this kind of a filter on a bivariate, first interim analysis, second, and third, and we have those similar kinds of filtering processes happening. So we can only continue this trial when it comes through the white space. So what happens? Well, these are the probability contours, and as Robin might say, holy lumps of bivariate probability, Batman. So you get some very strange probability distributions, and yet this is, we have to, if we're going to make proper inference, this is the stuff we have to work with. If we can't do confidence intervals, we can't calculate power or type 1 error rate, whatever it is in a bivariate space, unless we work with the proper sampling distribution. And so what does this tell us outside of the Batman, back to the Bat Cave here? These are the power contours for that kids dot monitoring plan, so I can go and figure those out. So I have 97.5% power or more if I'm down in the benefit range. I have only 2.5% power if I'm up here, where we agree that, although VTE is protection is increased, the bleeding risk is too high, or down here, where VTE risk, the bleeding risk is reduced, but VTE at the expense of VTE. That's the kind of power contours that we can start to look at in order to assess both the scientific credibility of our decision criteria, and then if we would need to modify that. How does this compare to a fixed sample, the univariate monitoring that I was talking about? Well, here we get a huge reduction in power up in this quadrant, which is where we'd want. Power is similarly low down here, which is what we want. And so this is the comparison between standard methods and then the curves being new bivariate monitoring. What does this do for trial efficiency? Well, this is numbers per group, but we can look at the expected sample size. So this is largely the full trial. If it's efficacious, we're going to largely go to the full sample size, but if it's not, we're going to be saving a lot of patients having to go through this study receiving suboptimal care. So that's kind of the point of doing any of this, is to get more efficient and more scientifically relevant trials. And so what I have in terms of summary remarks on this are, what we want is scientifically meaningful and efficient designs. This bivariate monitoring plan is feasible in that regard. The decision criteria, we can have scientific clinical relevance, increased probability of early termination if the VTE increases are not offset by bleeding reduction. And we can have trials with smaller average sample sizes for harmful effects. And I could achieve similar efficiency if I'd have had stopping for efficacy. So this is a one-sided stopping situation, but that can be monitored. So where does this generalize to? This is my last slide. So I don't have to think about a clinical trial. What about intermediate endpoints, to pick up on Tim and David's discussion? How about mediators, looking at mechanistic relationship? Can I use one of those as a surrogate and the other as a primary? I have a question mark here because surrogate endpoints have their own problems, but at least you could formulate it this way, in which you could start to look at trade-offs between those. Are late effects mediated through early time points? You're going to see emphasis on mediation here. So whether targeted therapies are mediated through the targeted pathway is a primary outcome mediated through a surrogate. And so these are the kinds of the questions, these are the things that this expands to, in addition to the statistical aspects of it all. So with that, I'll retreat. And questions? Yes. So I think it's a yes. Good question. How about that? That's right. So do early effects predict later effects? So that was one of my last points here is, well, what if you've got, can I use early effects in a trial on fewer patients to say, I've got enough information early and the correlation structure I'm seeing in a few people indicates that I probably haven't enough information on early endpoints to make decision about later ones. So now back to can you stop early? That's the group sequential aspect of it, is I can do that analysis with less than everybody in the trial and make a decision on whether or not I've got enough information in order to, on the combination of endpoints in order to stop now or to continue enrolling more people. Does that get at what you were asking? Okay. Anything else? Do we have time? Okay.